is there, but it is not discussed primarily because a lot of times patients don't land up coming to you, and they just keep switching from various alternative medication to just figure out what is the method to deal with it. And I would like to acknowledge Dr. Naresh Butula, who is an attending consultant in the breast surgical unit, who has helped me with this presentation. So it is actually a very common problem. Like I said, it is not discussed very frequently, but the fact is it is there and we cannot really wish it away. So what happens is that the reason why patients come to you is because they think that breast cancer is associated, pain is a symptom of breast cancer. But the fact is that pain is not a usual symptom of breast cancer. You would find pain as the only presenting symptom in about 7 to 8% patients only. For most of the patients would present with a painless lump. And the important thing to understand is that one should not go overboard with treating mastalgia, because most of the mastalgia will settle down on reassurance or placebo-like drugs. You don't even have to give them anything fancy to get rid of the pain. But the important thing is, in your reassurance, you have to make sure that the patient's fear of cancer is also allayed, because this can really have an impact on quality of life. And if the pain is such that it is affecting her to the point that she's not able to carry out her daily acts of living, then that is when you need to look at treatment options. So before we try to figure out what mastalgia, you have to classify it into whether it is cyclical, is it non-cyclical, or is it a chest wall pain, because there is always this confusion. So if it is cyclical, it is usually present a week to 10 days before the periods. That's the luteal phase of the menstrual period. And it is of a diffuse nature, and the patient gives you a very classical history saying that I have pain which comes on a week, 10 days before my periods are to start. And once the periods happen and go away, and I'm fine. Non-cyclical ones are the ones which are not related to the menstrual cycle, and you can have trigger points within the breast, or it could be diffuse, but it can be a pain which has got definite trigger points. And then, of course, there could be chest wall pain, usually unilateral, and usually on the side of the dominant hand, because it does have muscular elements associated with it. So pain from cyclical hormonal effects are, like I said, associated with ovulation, and it could also be associated with various drugs that one may be taken. So what estrogen does is that it allows for the proliferation of ductal elements, whereas progesterone stimulates the stroma, and it is involved in extracellular proliferation, and prolactin stimulates ductal secretion. So these are the three hormones which are actually acting on the breast. And we do use this term very loosely, and that is fibrocystic breast conditions. This is painful nodularity, painful nodularity is the clinical component. This is something that you feel also. When you examine the breast, you find nodularity across the breast with no definite lump within it. And then when you look at the histology in such breasts, you would find that this is fibroadenosis, which has got both a fibrous element to it and a cystic element to it as well. So like I said, cyclical pain occurs 1 to 2 weeks before the onset of menstruation, is usually bilateral, it is diffuse, and then it does not necessarily have a certain character to it. It could be stabbing pain or a sharp shooting pain. There could be a heaviness, which is the usual symptom. There could be an ache, and usually presents in the 3rd decade. So we have to look at various tools to assess the pain right, and that is with the help of a visual analog score. And if the pain severity is greater than 4, then that would qualify as cyclical mastalgia, and the duration of the pain should last for at least 7 days a month. That would be the criteria for diagnosing cyclical mastalgia. So if you look at non-cyclical mastalgia, it typically occurs in the 4th to 5th decade. In perimenopausal women, it is usually unilateral, and it would be limited to a certain quadrant. It could be constant, it can come and go. There could be waxing and waning patterns to non-cyclical mastalgia also. So when you examine such a patient, you will find that there is a lot of nodularity. There are areas that are very tender, may or may not be associated with a nipple discharge, and usually there are no local signs of inflammation. So it is actually a very characteristic pain in the breast without any signs of mastalgia. Uh, Sorry. Yeah, so various lesions that can cause non-cyclical mastalgia could be cysts. Cysts are known to release inflammatory mediators within the breast, and that is what gives rise to pain. Periductal mastitis is also a well-known entity, and it is typically mastitis or inflammation present in the vicinity of the areola. And sometimes when there is inflammation, there could be stretching of the Cooper's ligament, which again can give rise to pain. If there has been some trauma, there could be fat necrosis, and that fat necrosis can be quite tender. Mondo's disease, where we all know of, thrombophlebitis of the vein along the lateral chest wall, and sometimes even below the in the subcostal area, or there could also be diabetic mastopathy. So when I say extramammary or non-breast pain, we are essentially talking about the chest wall. So it arises from the structures around the breast, and it may mimic breast pain. It could be a referred pain to the breast, but it is the chest wall that is the usual culprit, and it is usually unilateral. And you're very well aware of this term called teeth syndrome, which is costochondritis, usually of the second costochondral junction, but you could have costochondral inflammation above and below it as also, and there could be nerve root pain. So you'll have patients coming with pain in the neck, which is radiating to the arm and to the upper chest also. That could also be perceived as breast pain. There could have been some sort of surgery which has happened, and after surgery, it could be pain because of the surgery, and sometimes you can have nerve entrapment syndromes also, which can again give rise to pain that doesn't settle down after surgery. There could be herpes zoster. Herpes zoster could heal, but that band-like pain can persist for months and sometimes even up to years. And there are other conditions which can be perceived as breast pain, which are of a more serious nature, like it could be an MI, which is showing up as pain in the left side, but could be interpreted as breast pain. There could be biliary pain or reflux esophagitis. All of these can also give rise to pain in the area of the breast. Then there could be certain endocrine abnormalities like increased estrogen secretion from the ovary, or there could be a deficient progesterone production and hyperprolactinemia. So the important thing to understand here is two hormones, the rise in two hormones, which is estrogen and prolactin, and a deficiency of the third hormone, which is progesterone, can give rise to mastalgia. So what happens with this is that before periods, there is salt and water retention in the breast, and that is what, because of the stretching, one does have mastalgia. But it is also important to rule out, once you've ruled out the pathological abnormalities, you should also look at functional aspects to mastalgia. So it can be associated with psychiatric conditions. There are unexplained pain syndromes. There could be a cluster of unexplained pain syndromes, and this could be one of them. So that also needs to be assessed. And if you look at various factors that could be the lifestyle habits that could be associated with mastalgia, excessive intake of caffeine, methylxanthines, smoking, also alcohol. Alcohol consumption on a regular basis can also give rise to mastalgia, and then aberration in lipid metabolism, and high intake of saturated fats is also associated with mastalgia.